Hi, welcome everybody. As people trickle in and get some lunch, I want to welcome everybody to Pediatric Grand Rounds. Dr. Hirsch cannot be here today, so I will do the introductions as the Vice Chair for Education. I want to, because it's the last Grand Rounds in this series for the academic year, I want to do a special shout out to our planning committee. Some of the members of the planning committees are here, including Jim Byer and Meg McNamara, and I think that's who I see in person here. I'm pretty sure a number of them, oh, and Libby Birch, a number of them are also online. They've really helped us select topic speakers to create a very diverse offerings of Grand Rounds speakers. A special shout out to Jim and Meg, who I think also win the Pediatric Grand Round Attendance Award of 2022-2023 are here every single week. So we really appreciate that support. As I mentioned, this is the last Grand Round. We will resume after Labor Day. Emails will be sent to you. We're taking a break over the summer, but our last topic and speaker for the year is Dr. Stefan Friedrichsdorf. He sent me both a 2-page bio and a 2-sentence bio. So I'm going to try to do it justice by getting somewhere in the middle there. Dr. Stefan Friedrichsdorf is a professor of pediatrics and chief of the division of pediatric pain, palliative and integrative medicine at the UCSF Benioff Children's Hospital in San Francisco and Oakland. And he actually just told me that he rushed over from Oakland, where he's attending this week. So we appreciate him making the time coming here. He received his MD degree from the Medical University of Lübeck, Germany, completed a residency at the University of Witten-Herdecke in Germany, and undertook a fellowship in pediatric pain medicine and palliative care at the University of Sydney, Australia. He's double boarded in pediatrics in Germany and in the United States, a diplomat of the American Board of Pediatrics, certified in hospice and palliative medicine, and trained in pediatric clinical hypnosis. He's the medical director of the STAT Center for Pediatric Pain, Palliative and Integrative Medicine, which is one of the most comprehensive programs of its kind in the country, with an interdisciplinary pain program that works with in close collaboration with all clinicians and subspecialties at both Benioff Children's Hospitals. The palliative care team and integrative medicine are also part of this center, and he has received the prestigious Childkind International Pain Relief Certification and the Joint Commission Palliative Care Certification for this center. He is the lead physician in a number of important initiatives, received various awards, including the 2016 Outstanding Educational Achievements in the Field of Pain by the American Pain Society, and the 2011 Hastings Center Cunliffe-Dixon Physician Award. There's much more on these 2 pages, including a lot of media and video links describing the work that he has done, which I'm pretty sure you can find on his UCSF profile page. So I'm going to now invite him to give a talk here about chronic pain to kids and their parents.
Good afternoon. The last Grand Rounds of the year. Thank you for coming. Sandrine, thank you so much for the kind introduction and the invitation. And so we are going to talk about software problems, unrelated to hardware problem. How do we explain chronic pain to kids and their parents? I have nothing to disclose. These are my handouts. You get them as well. If you use your phone and use the QR code, you get every single slide and a few articles. So if you have any trouble falling asleep tonight, you're very welcome to look through them. And as Sandrine said, I'm the very proud director of the START Center for Pediatric Pain, Palliative and Integrative Medicine. We actually have 3 team members here. Thank you for coming, including our pain psychologist extraordinaire, and Christina, whom I will ask to answer a question at the end about chronic pain as well, if that's fine. All right. So what are we going to do? In the first part, we sort of look at chronic pain. It's something super common. And let's look again, what is the underlying pathophysiology of chronic pain in kids and teenagers? Like, how can we best explain this in children with no tissue injury and in children with tissue injury? And then we talk about that the only way we know to make this really, really much better is an interdisciplinary rehabilitative approach. And we're going to talk about those treatment choices. And then we will talk about how unimportant or even dangerous medications are in most of those situations and why opiates are contraindicated for kids with chronic pain. And then in the second half, I will share sort of a few pieces of language, both Dr. Benke and myself, and our pain team is here, Dr. Karen Sun and Robin Allen. So what kind of language do we use when we need to explain this to kids and the families that the pain is real, but the MRI comes back normal? So how do we sell that? All right, so these are feet of children. I have 3 kids under 3, so they're a bit older right now, right? And so they tend to jump on trampolines. And many kids, most of the kids will in their career will sprain the ankle. And most of them basically will end up having an owie in the ankle, which is sprained for a minute or an hour and a day. And then they go on with their normal life. And then once in a while, there's this kid who sprains the ankle on the trampoline and then suddenly has back pain, and it ends up in crutches or a boot or in a wheelchair and is dropping out of school. And so what's different about that foot and that ankle versus the other one? Some even develop a complex regional pain syndrome, CPS for that matter. So why this child and not any other ones? So let me give you a case example. I've done this for 20 years now, and have run one of the largest chronic pain clinics in the country. And so this is not a real patient. This is just sort of like a comprehensive version of a complicated pain patient. And this is thank you to the godfather of chronic pain, one of my teachers and mentors, Neil Schechter, who just retired at Boston Children's Hospital. So it's not a real case. Let's call this patient Jaden. Jaden is a 14-year-old with a 3-year history of tummy aches, pretty much around the belly button. And it worsened last September, so coinciding with attending a new school. Had good healthcare, very parents are top on, and has seen many physicians and clinicians over the years. So had several endoscopies, repeated lab investigations, imagery, CAT scan, MRI, ultrasounds. All of those were pretty much normal or negative. Over the years, she was prescribed numerous medications. All of them either didn't work or caused bizarre side effects. More lately, a year or so, she has trouble falling asleep. She now actually sleeps with her mom in her bed. Dad is sort of sleeping downstairs. Mom is very well organized. You've met her many times. She comes with a color-coded folder. She has 2 neurologists on speed dial on her phone, so she knows how to get hold of people and doing this. A mother's awesome. Mom is basically there all the time. She massages her shoulders in doing your session. She attends to her at night, and if Jane wakes up at 3 o'clock in the morning, she would massage her feet until she falls asleep again. Jane also developed really bad headaches. And those headaches were so bad that really she's not too tired, like can't really fall asleep. She's too tired to get up, and often sleeps until 11:30, noon, 1:30, and then takes naps in the afternoon, and then has trouble falling asleep in the evening. In fact, she has missed more than 35 days of school in the last school year. And when she goes to school, she usually sees the school nurse about once or twice per day. So this constant bifrontal terrible headache, which is there every day, every single moment of her life for the last 8 months, also causes her to sometimes that her eyes going blurry. She reports that she's sometimes blacking out. Nobody else is seeing this, but that's sort of, she describes it as this. So of course she had a workup by neurology, by an ophthalmologist, had another CAT scan, another MRI, EEG, all of which were normal. She was super active and then became less and less active, and probably as a result of this started to have musculoskeletal pain. Started to have pain in her knees and her ankles and her shoulders and her back. And so she had an exhaustive workup by pediatric rheumatology, by an orthopedic surgeon with x-rays, exhaustive labs. All of them were sort of negative, or then something was positive, but really didn't sort of bring us anything further. Jane is your patient, and she has been in the emergency room 5 times in the last 12 months, resulting in 2 hospital admissions at Mrs. P's request. She was seen by numerous specialists and has been received many diagnoses. Some of them would we call Münchhausen by doctors, so they wouldn't really be applying. Right? She was clearly diagnosed with POTS, autonomic dysfunction, dysautonomia, chronic Lyme disease, despite the fact that her Lyme title has always been negative, acne, abdominal cutaneous nerve entrapment syndrome, mast cell degranulation, Ehlers-Danlos, although she doesn't fulfill the criteria, and long COVID, despite the fact that she doesn't seem to actually have had COVID. Chiropractors found yeast in her stool, so they prescribed antifungals. He saw some clots behind the eyes, so put on a blood thinner and started heavy metal chelation therapy for heavy metal toxicity, and performed several adjustments without obvious effect every time. Mrs. P appears a little bit on the worried side to you. She is very, 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 very worried that over the last few years, something terrible has been missed. And it's Friday afternoon, 5:30 in the emergency room, and she requests an explanatory laparoscopy. Otherwise, she's not going to go anywhere. She herself has been diagnosed with fibromyalgia and basically has stopped working in order to attend for her daughter. In fact, this overwhelming pain and fatigue and inability means that Jaden is not attending a brick and mortar school anymore. She's supposed to attend an online school, but because of timing, that also doesn't work. So she currently is maybe doing 10 or 20 minutes a week. She also has stopped meeting her friends. Has basically no social life because they don't understand what's going on, and she is not doing any sports anymore. Among other things, she was a competitive figure skater until the age of 3 and practicing 7 times a day. All right, she's your patient. Friday afternoon, 5:30. Next steps. Shout it out. Yes, has any one of you ever seen Jaden? Yeah. So I see some nodding, some hands up. Yeah. So yeah. All right, we're in trouble. We are in trouble. You can look at the literature. I think this is brilliant articles in handout, but then of course I'm very biased because I know the first author, but really sort of talks about sort of like, what do we know about those kind of kids? How do we get back to normal? And basically, a proper treatment plan, the best research we have, would include doing 4 things at the same time. We come back to this at the end. Basically said to start physical therapy and daily exercise, to invite active mind-body techniques, something Jaden is doing herself, deep breathing, hypnosis, biofeedback, something like that, psychotherapy, and normalizing life. First, she goes back to school, then the pain gets better. First, she normalizes sleep, then the pain gets better. And absolutely no infusions, no ketamine infusions, no opioids for this matter. All right, great plan. What could possibly go wrong? Shout it out.
Everything.
Everything. Yeah. Tell me more.
It sounds like Munchausen by proxy.
Yeah. So this could be Munchausen by proxy. Yeah. We assume that we talk about this is sort of real pain. Yeah. But you're absolutely right. But this is going on for 3 years. Yes, please.
I feel like when I've had patients like this picture, they're like looking for family wants an intervention, which I can empathize with.
Families want intervention. I'm just repeating for the Zoom.
Yeah. They want like a treatment or like.
They want a treatment.
None of that on the list is gonna, I don't think, fulfill that that understandable desire on their part.
So none of this is sexy enough to sort of like that the family will give us any buy-in, right? If you start, okay, let's do a ketamine infusion or let's admit them for some sort of infusion, that is well paid and will be sort of covered, right? Okay, so we have to sell it. Yeah, how do we sell it? So let's go a step back and what the heck is pain? Yeah, or to quote basically a certain Supreme Court justice, like I know it when I see it. So if we are taking care of Jaden or any other patient in your care, and the pain is 8 out of 10, what the heck does that mean? Does that pain mean this is acute tissue injury? This is nociceptive pain caused by a broken bone, caused by a burn, caused by tissue injury, caused by mucositis. So where we know that the tissue injury is sort of causing this, and this is, so is that acute pain, nociceptive pain? Or is this visceral pain? This could be a bladder spasm. This could be kids with a tumor inside the liver. This could be kids with a slow bowel movement. So, and that's something we treat completely different. Is that neuropathic pain? A large number of children with serious illness will develop neuropathic pain or treatment. And again, we would treat this completely different than either of the two. Might this be psychosocial spiritual pain, total pain, which is real pain? That's 8 out of 10, but you can never treat that with methadone or morphine or ketamine. Or is this chronic postoperative pain? Data from Joe Katz in Toronto seems to suggest that up to 20% of children do develop chronic post-surgical pain at the location of the surgery 6 to 12 months later. Or, and that's what we're going to talk about today, and or is this chronic pain beyond the expected time of healing? And every time you are seriously thinking of drinking a proton inhibitor straight out of the bottle because you have a really, really, really difficult patient like this, most likely it's 1 or 2 or 3 or 4 or 5 of those at the same time, and not just one. All right. The problem is pain is not well treated. Pain is often not well taught. When we teach pain to our fellows, to our residents, to our nursing students, to our colleagues, to parents, we still are basically in the 17th century. We're thinking René Descartes, an amazing mathematician and philosopher who brought us Cartesian mathematics, who drew us this picture. So there's this dude who puts his foot in the fire, right? And then you have a wire between his foot going to the brain and you feel the pain. This is how most people, how most of our colleagues still conceptualize pain in 2023. Of course, we put this in somewhat nicer words. I would say like, okay, I sprain my ankle, my bowling ball falls on the foot, I put my foot in the fire, so I have nociceptors, and basically what happens that myelinated A delta fibers and non-myelinated C fibers shoot up the information, the nociception, into the lamina 1 and 2 in the dorsal horn, and there it crosses over at the synapses using pain transmitters, substance P, glutamate, and then it polarizes the second neuron, and then the spinal thalamic tract sort of reaches the thalamus, and then prefrontal cortex, and then we feel pain between 0 and 10. I basically just told you exactly the same what René Descartes was talking, just in a little bit more sort of medical terms. Point is, that's absolutely, this is not how it works. The idea that there's a wire connecting our foot to the brain like some sort of pain nerve, that's called the naive view by neuroscientists. This is a grotesque oversimplification of what's happening on lamina 1 and 2 between the first and the second neuron. And you see that the pain information, when it crosses over, it's modulated by microglia and astrocytes. So I'll give you 10 seconds. There will be a test at the end. So just like look at this grotesque over simplification, just like you to look at every single receptor here. And especially at the microglia 1, take as many moments as you like. Good, fantastic. That actually only works in male mice. Researchers don't like to test female mice because they have a period. No joke. So we don't actually know what's happening on female mice for that matter. It seems to be that maybe T cells are more included. Bottom is, if I sprain my ankle, if I put my foot into fire, basically, and I put my brain into an fMRI and I sort of see which parts of the brain light up, we actually, starting from the periaqueductal gray, going all the way to amygdala and to hypothalamus, we can actually stimulate descending inhibiting pathways. And that decreases the amount of pain. Sandrine, if I come over right now and hit you as hard as I can on your leg and then ask you what's your pain number, middle-aged white dude hitting you in front of your colleagues. That's an 8 or 10 out of 10. That's basic. That's dangerous. This is a dangerous situation. Your brain wants to get out of this. If you not play soccer and we are in the same opposing team and I accidentally run into you and make the same injury, you may not even notice this. And afterwards in the evening think, oh, where did I get this bruise? So how much pain I feel has nothing to do with the amount of nociception reaching the brain or the tissue injury, but the interpretation, whether or not This is threatening to me at this very moment. So this dip, descending inhibiting pathways, can of course be stimulated by distraction. Playing soccer is awesome. Integrative modalities, hypnosis, biofeedback, rehabilitation, exercise, getting out of bed, not sleeping until noon, psychotherapy, social life, sports, exercise, sleep hygiene, at going to school. That decreases the amount of pain. And on the other side, the opposite is happening as well. We know, coming from the thalamus, which is the computer chip in your brain, sort of processing the pain information to higher regions, all the way to our prefrontal cortex, we can actually using facilitatory ascending input, which worsens, increases measurably the pain transmission between the first and the second neuron. And stress, anxiety, we're going to talk about catastrophizing in a second, depression, avoidance behavior, not exercising, perceived injustice, disturbed sleep, not going to school, significantly increases this. And if the yin and yang of the inhibitory and facilitatory inputs, if this is out of control, if this is disrupted, then we talk, and this is what's happening in Jade and so many of our patients, when we have a central sensitization. In other words, if I have pain in my ankle or in my bladder or in my head, there are thousands of neurons, there are dozens of pathways, there are dozens of neurochemicals and receptors, and hundreds of signal transduction players within each neuron in the circuit. So the idea that we can bring somebody and start an infusion of some stuff and then this is going to better is laughable. As I just give the example with Cedrine and me, it's basically pain is in our brain. Yeah. Is this information interpreted as a threat or not? All pain is real, no matter what is causing it. But also all pain is made by the brain in response to the information available. So if our patients are flipping out at 3 o'clock in the morning because they're in pain and they think that whatever is going on is bad for them, they will have a lot of pain. So going back to the trampoline, and why does some kids are pain-free in an hour and some kids are in a wheelchair? So what we're going to talk about, of course, is the biopsychosocial model of pain. And we will talk about biology, psychology, and social impacts for that matter. So what is chronic pain? The adult WHO definition is, of course, completely useless. Yeah. So this idea is like, if you have pain for more than 3 months, then it's chronic. That means, okay, if it's 2 months and 28 days, then it's acute. Yeah. And then tomorrow it turns into chronic. This is rubbish. And we have, I'm currently the president of the International Association for the Study of Pain for the Pediatric Special Interest Group. And the WHO is just like, this is it. We're not going to change this. Yeah, they're just doing this. So basically what pain specialists like myself, we're using is chronic pain in children or teenagers or young adults, pain that extends beyond the expected time of healing. Pain which extends beyond the expected time of healing and has lost the warning function of physiological nociception. If I put my hand on a hot stove, the pain tells me, take your bloody hand off the stove. That's good information. This is a warning sign. Yeah, that's like a car alarm or a smoke detector. That is good information. But if my ankle has healed, the X-ray shows there's actually nothing broken, but it still hurts. That means this is not a problem of the ankle anymore. Yeah, this has become chronic pain, and this can happen after a week or 2. We don't have to wait 3 months to define chronic pain. So I will just give you like a few examples of some of my patients. Usually when they graduate from pain clinic, I invite them to videotape and sort of talk to me about them, sort of what happened. Nick, we are sitting in a pain clinic right now. Tell me, when I saw you for the very first time last year, why did you come here?
I was missing a lot of school and I had headaches every day. And I just could hardly even get out of bed. The headaches were so bad, I couldn't even look at lights.
So, and how do you feel now?
I feel great. I was a little overwhelmed at the beginning because it sounded hard. And it was hard. It's not taking a simple pill once a day. It's hard work, but it pays off in the end. I had headaches for over a year. Now I'm headache free after a.
So he spent 8 months in a row in his bed because of daily chronic bad headaches. So a large number of kids have pain. If I go to your home county and I go to any middle school, to any high school, and we make a survey among kids, probably anywhere between 10 to 40% of children have severe chronic pain, bad enough that they would miss school, bad enough that they have some sort of limitations. So it's super common. However, only a small piece, maybe 3 to 5% of children actually where this chronic pain translates into a disability. They actually experience significant pain-related disability. And our own data has shown that if we go right now and ask our inpatients at the moment, that at least 10 to 12, 20% of all our inpatients also experience chronic pain. In addition, separate usually from what is going on. So is that gender dependent?
2, 3. Keep pushing!
Are you okay?
You have no idea how much this hurts. Keep going! Keep going!
So all data is showing that the prevalence of chronic pain is the same before kids hit puberty among boys and girls. Once they hit puberty, the prevalence among girls is 4 to 6 times as high. Boys often choose other bad things, conduct disorder or other things. That's a different talk for that matter. We also know that the big trigger of those are ACEs, the adverse childhood experiences. And our pain psychologist, Dr. Benke, was leading and implementing. We actually are asking for ACEs for every single patient coming to our clinic. And data has shown that, not surprisingly, the more adverse child events you have, the more likely you are to develop chronic pain. And in financial instability, living with a mentally ill person, discrimination are actually the 3 highest related measures which are associated with chronic pain in kids and teenagers.
Excruciating amount of pain. It was in my right ear. It was kind of in this area.
Right.
And it felt like knives were constantly stabbing my ear.
So how were those days? How were those nights?
Miserable. I couldn't even sleep some nights.
That's painful for family too, to see your child in a state of distress that you can't fix. I think the hardest part was the over and over told, well, this is really more art than science. And we're just gonna have to try different drugs and figure it out. And from starting here and saying in the back of my mind that we're always gonna have to be on meds, we're always gonna have to manage pain, we're always gonna have that day where the screaming might start again, and the screaming was unbearable. It was like listening to your child break a bone and not being able to do anything about it.
So what is most likely, why does this child twisting of the ankle on the trampoline end up in a wheelchair or on crutches or on a boot and is dropping out of school? Among several things, number one is the fear of pain, the belief of the child and the parent of how detrimental pain will be. Pain is supposed to be a warning sign. If your knee's broken, you're not supposed to run on this. I don't say, Sandrine, your knee's broken, just trust me, run on it. It will be good. That would be bad for you. Yeah? So the understanding that the pain is there, but it's not broken, actually walking on this, pain may get worse, that is a key driver of why some kids are in pain. Absolutely key and central is there's a huge amount of literature is catastrophizing, awfulizing. So this is a set of negative emotional cognitive processes like magnification, ruminification, pessimism of what is going on. And there's obviously a significant link between parent and patient and catastrophizing. And we actually know that the higher the catastrophizing, the more likely is that kids after surgery will develop chronic post-surgical pain. Underlying anxiety is huge. Yeah, we know that kids who suffer from chronic pain substantially suffer more from anxiety and depression compared to healthy. The comorbidity is 50 to 80%.
I did relaxation strategies such as deep breathing and Woody and Buzz, which is where you tense your muscles and let them go.
progressive muscle relaxation. Anything else?
Oh, going to your happy place and getting a good night's sleep.
All right. What about Andrew?
Andrew, he kicked my butt. I'll be pretty honest. He put me back into shape and told me what I needed to do every week.
So working with physical therapy
Was difficult, but it paid off. I needed to get back in shape for the hockey season.
So in the past, we had this idea, which now is found to be wrong, that we have this child who's pain-free. And then, so we have this idea there's like some sort of like transition from acute to chronic pain, right? And then there's some sort of tissue injury, sort of they're breaking the ankle or having a bladder infection or something like this. And then the tissue injury is sort of causing acute pain, and then the tissue heals, and then somehow chronic pain sort of comes out of this acute pain. That's probably not what's happening. So this probably oversimplifying what we thought that is sort of acute and chronic pain or chronic and acute pain. That's probably not real. So this is a hypothesis which actually has not been proven, and it has certainly never been proven in humans that there's like central sensitization is sustained after the tissue is healed, and that the afferent input has ceased, and that this drives chronic pain. So we probably rather than we probably do not have to consider a transition from acute to chronic pain, but it's probably something which develops in parallel. Yeah, so these are different pains which are happening sort of at the same time. And when the acute pain goes away, the chronic pain remains. It's probably a long-standing, it's likely that this is a long-standing pain that represents a new mechanism. And it's basically right now at the center of major research, as you can imagine. So we know, if I go to any high school right now, that about 5% of children have severe chronic pain, headaches, chronic tummy aches, joint pain. So that's normal in the normal population among our children. That means if you do something in pediatrics, you're a hospitalist, you are a hematologist, you are an oncologist, you are a cardiologist, that obviously that in children who have something else, who have sickle cell disease, inflammatory bowel disease, rheumatoid arthritis, congenital heart disease, cancer, and so on, that at least 5% of those children also have chronic pain, completely independent from the cancer or completely independent from the inflammatory bowel disease. And then, of course, we know that the more often you're in the hospital, you're sick with something, the risk of developing chronic pain goes up from 5% to 10% or 15% to 20%.
You came here, right?
Yes.
And started to do lots of hard work.
Mm-hmm.
So how are you today?
I'm amazing.
Tell me about that.
I am currently a successful horseback rider, and I also enjoy lots of fencing, and I play Minecraft a lot and I love to read and do lots of fun stuff
Great. And what happened to your pain?
in my life.
So you're pain-free now?
Yep.
So let's wrap up about the pain pathophysiology. What do we know? We now know that chronic pain basically is not a problem of the location. It's not a problem of inside your head when you have a chronic headache. It's not a problem of inside your belly if you have chronic tummy aches. It's not a problem in your back if you have back pain, but it's a manifestation of an underlying vulnerability rather than a separate disorder. So it's a shared biological sensitivity. Until very recently, we sort of didn't know, is that normal brains have something happens and then develop chronic pain, or do they have this predisposition before? And it seems, at least according to this study, that something happens before. So they took a large number of children aged 9 to 10 who were pain-free, and then those who developed some sort of chronic pain over the next year, they were then controlled to children who were pain-free at both time points. And they found that the increases in activity and functional connectivity between pain-processing brain regions existed before the onset of the multi-site pain. So the software problem was there before anything else happened, which is quite interesting. So going back to the biopsychosocial problem, biological means that there is, of course, a high family chronic pain history. So you often find parents with migraines or chronic headaches or fibromyalgia or abdominal pain with that. And then biology means also there could have been a trauma, a microtrauma, an infection, some sort of injury. Social means, of course, early life stressors. We talked about ACEs, school, bullying, having academic problems is another bit. Social media is a big thing. And then on top of that, parents who could testify saying, "Oh my God, your pain is so bad in your foot, you need to stay home, right? This is not working." And then there's some psychology on a patient who has underlying anxiety or depression or increased stress intensity. If this falls into a brain, as we just talked about, who already has a disordered pain processing, so an imprecise encoding of threat. So I'm so strolling by Sandrine and hit her. That shouldn't really hurt her. But suddenly this information is interpreted by brain as severe pain. So that's the imprecise encoding of threat. That then becomes what we used to call a functional pain syndrome, and now what most pain specialists like myself would call a primary pain disorder. So a primary pain disorder means that we have pain in different parts of the brain, of the body, and it cannot be explained by in terms of conventional designed medical disease. The tests usually come back normal. However, they're associated with significant disruption of everyday life and often incapacitated. And the stuff we usually do doesn't work. They're not responsive to conventional medical therapy, however, consume an enormous amount of radical resources. The more specialists are involved in a pain patient, the more likely it is that you have a primary pain disorder. And often it's basically the family and the kids basically feel, because we don't find anything on the test and memorize, we don't believe them. So it's pejorative. So it's not organic and therefore not real or serious. A primary pain disorder is it's the same pain, it's just on a different part of the body, which will be treated exactly the same way. So it could be a primary headache, a chronic daily migraine, or a chronic daily tension type headache. It can be in your belly. So this could be a functional abdominal pain syndrome or centrally mediated abdominal pain syndrome, an irritable bowel syndrome for that matter. Or it could be widespread chronic musculoskeletal pain. Fibromyalgia is not, there are no criteria for kids under 18, so we can't define this, but the widespread muscular pain, some people do call it juvenile fibromyalgia. The rheumatologists have a term called amplified muscular pain syndrome, EMS. Cardiologists may call this non-cardiac chest pain. And complex regional pain syndrome, actually, interestingly, seems to go under that as well. Most kids we see in a pain clinic obviously have pain at 2 or 3 locations at the same time. All right, so we have Jaden, real pain. All tests are like negative or not really sort of going anywhere. And what this means is that basically the family hears from us, your pain is not real. You're crazy, go somewhere else. So in other words, the hallmarks of chronic pain in the eyes of the family is that it really differs from the patient's traditional understanding of pain. It is not warning sign. It does not represent ongoing or current tissue anymore. It is not protective anymore. In fact, you need to walk on that ankle in order to make it better, not protect it with a boot or in a wheelchair. It does not display signs of sympathetic arousal. So usually I don't have like increased heart rate or tachycardia, blood pressure or others. And you often have very bizarre symptoms on top of this. Pain is in multiple locations, on and off, and there's some allodynia, even gentle touching, and then comes and goes. They're all 100% orthostatic intolerant, right? So because they're deconditioned, then they become dizzy and nausea, fatigue, and it's not responsive to what we usually do for acute pain. So what Jane's mom wants, she wants more testing. So Dr. Cox, in this patient with high health anxiety and chronic pain, is further testing going to reassure them and help the healing?
Good God in heaven, Nubi, there are just so very many ways for me to say this to you. Never, not in a million years, absolutely not. No way, Jose, no chance, Lance, yet, negatory, nah, and of course my own personal favorite of all time, man falling off of a cliff. No! Oh, Dr. Cox.
So how much testing is enough? In patients and parents with high health anxiety, continued testing provides only very, very short-term relief. It does not provide long-term reassurance and actually fuels further catastrophizing, further anxiety of, and clinical symptoms. What we know sort of in the pain world is that the best form of reassurance is to provide an explanation, which I'm going to start with in a second, and frequent follow-up. So in other words, what we have is that the chronic pain, the primary pain disorder, is real pain. That is real pain. They're not making this up. They're not crazy. They're not faking this up. But if this is an age group where an iPhone or Android phone or computer technology will work, I will explain to them it's not a hardware problem. It's not the tissue injury. There's nothing wrong with the hardware of the computer, but it has morphed to a software problem, the central sensitization. This is like if I take an X-ray of my iPhone, if the software is not working, everything comes back normal. The MRI, the ultrasound there will not show anything wrong. So in other words, the pain we see, the headache, the tummy aches, the musculoskeletal pain, or wherever it is, it's just a symptom. That's the tip of the iceberg. If we do not understand what's under the water for that particular iceberg, we will not be able to treat this. And it will never be just a question of let's admit them, give some sort of medications, and then sort of going home. That will not help long term. So pain clinics, how long can we wait? It's not clear. After 6 months, usually the wheels are falling off the bus. So probably kids with chronic pain need to be seen by a pain clinic within 6 months. However, we only have like 2 handful of pain clinics in the country. We have a waiting list of 5 million years. And most pediatricians feel that's not their job. Somebody else needs to do this. So there's a nice pediatric pain screening tool by Laura Simons, which in Boston, which you might choose if you think, okay, is this somebody I need to refer? Is this something I can basically get the system together in my practice? That may help you. All right. In the last 17 minutes, let's talk about the exit interview, the dog and pony show. So how would I explain to Jaden or other kids what to do? And we usually start after all we've met different members of the team, we've examined them, we looked through all the data, basically tell them that the pain is real. And probably 1/3 to half of the kids, they get the kids or the parents get tears in their eyes. It's like they say thank you. They feel that this is the first time that somebody said that, yeah, that pain is real. It's absolutely, absolutely important. That's the single most important thing, that we avoid diagnostic uncertainty. If the first time they see me, if the first time they see you as a specialist, and we waffle, well, I don't think it's any bad, but let's sort of do 17 more tests and I mean, it could be cancer, but it's probably not. I mean, I don't think it's a brain tumor, but yeah. So with that, they're going to flip out. And of course, some kids have really something bad going on. They have juvenile rheumatoid arthritis. You need to do something about this. They have Crohn's disease. Of course you need to. They have cancer. We have really sick kids where we can't waffle and we have to say, like, we don't know, we have to do further testing. But usually these are kids 1, 2, 3, 4, 5 years down the road who had a multi-million-dollar workup where you can be a bit more comfortable that this is truly a chronic pain. And so the first time they see me, they need to expect that they become pretty much pain-free. That's a self-fulfilling prophecy, big study showing that if chronic pain patients, the very first time they see a pain specialist, if they hear that they could become pretty much pain-free, they will. If we tell them there's probably nothing we can do with the pain, so then that is what's going to happen. So usually I basically like, Jaden, I'm a pain specialist. Like I do this for a living and I've seen like 5 trillion patients like you. I think your pain is real. I do not think that you're crazy. I do not think that you're faking this. I don't think that you're making this up. I think you have something super common. I think you have something which I see all the time. And I explain this to you in a minute. And I've got good news for you, and I've got bad news for you. You want to hear that? The good news is that I've seen many, 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 many patients like you. I'm absolutely convinced that you could become pretty much pain-free. And then I sort of give the asterisk. So what does pretty much pain-free mean? Does that mean I can promise you that you're never going to have a headache again? No. That you're never going to tummy pain? No. Ever have back pain? No. I said, I'm a pain doctor. I have sometimes back pain or headache. Normal people have sometimes pain. What I'm promising you is most minutes of the hour, most hours of the day, most days of the week, most weeks of the year, you will not have pain, and the pain will not bother you like everyone else. That's the good news. You want to hear the bad news? It's bloody hard work. What you've been doing in the last year, 5 years, has not been working. I need you to do hard work. I need to do 4 things at the same time, if you're interested. There's a risk, 50-50, that the pain may even get worse before it gets better in order to do that, because you're so deconditioned. 4 things at the same time, and then I usually go back and say, Jaden, you've really spent a lot of time in whatever of the 4 things you did with this. Yeah, you did physical therapy like every day. Yeah, you can marry a physical therapist. Alone is not going to be the answer. You need to do the 4 things at the same time concurrently, not 1, not 2, not 3, 4. And you're on board. Yeah, if you're interested in doing this, I'm here for you. We're here for you. We're happy to help you. If you don't feel this is the right approach, go free and get a second or third opinion, and then come back when you're ready. Do kids believe me when I tell them that they become pain-free? Of course, 100% of them. When I saw you, I actually told you, I'm absolutely convinced that you will become pain-free. Did you believe me at the time?
No,
Why not?
because every single time that we went to a pain doctor and stuff like that, they'd be all just like, "Oh, you're gonna be pain-free," and for your information, nothing happened. So, well, like pain. So hard to believe someone at the time after all the 4 years and stuff like that.
So for 4 years, people have told you?
I'll be pain-free, but nothing actually happened.
Mm-hmm.
So unfair, but yeah. Yeah, so.
Thank you. She did follow up with the 4 things, and she now is pain-free. So how do I explain this? It depends on the age, of course, and different things, but I usually do some sort of drawing. Yeah, as you can say, there's a reason I chose medicine over art. Yeah, so that's the patient. And let's say the pain is in the foot or in the belly or in the head, wherever it is. I'd like make a cross where it is. I pinch them there. So like where's this computer chip in your body? And they come that the brain sort of notices, and then said, this is a computer chip. I may or may not notice that this is the thalamus. We talk then about wire going from the foot into the spine, and then sort of up to the second one to the thalamus. And we talk about electricity sort of going up. Age appropriate, as sort of explained, giving like a sort of a pain model, very much in the 17th century style of the scout. And then I basically tell them that then from the computer chip thalamus, it goes to higher part of the brain, and then we feel the pain between 0 and 10. And so I tell them, and I spent about 5 or 10 minutes about sort of why pain is a good thing. Why, if you put your hand on a hot stove and it hurts, take it away. If you're walking on broken glass, then the pain tells you don't walk on broken glass. So this is acute pain. That is sort of tissue in you. This is protective. This is basically what our brain is wants to do. And so they sort of get this, that this is sort of a car alarm if somebody wants to steal the car, or a smoke detector if it's burning. That is good alarm. That's a good information. And then I may like pinch them, like, so what if I keep pinching you on your hand for the next 24 hours? Just nonstop. What would happen? And they usually get to the point, well, tomorrow it's worse. I said, so interesting, right? If I have the same pain on the same spot, it gets worse. In some kids, it comes and goes. Then I may say, how about I come back next week and do this again? What happens the second time? And then I come back in a week, the third time. So I change it to the story sort of this particular patient. But we always get to the point is if you have the same pain on the same spot repeatedly, it gets worse. Why am I telling you that? And then they sort of get, well, they had pain in the same spot for a long time, it sort of get worse. And then we talk about basically that in some kids, and the body heals, but the pain nerves just continue to send up this information. So I give some sort of a hypersensitive version. I usually talk about sort of hypersensitive nerve to just get on. It's not a problem of the ankle anymore. It's not a problem of the belly anymore. It's not a problem of your head, of your brain anymore, but those bloody pain nerves would just sort of send up wrong information. Yeah, so that's like a broken smoke detector or broken car alarm. Nobody wants to steal the car. It's actually not burning, but they go, mah, 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 mah. Yeah. And then if they're computer savvy, I may say that's not a hardware problem. This is a software problem. And this is why all the x-rays, MRIs, lab tests or something are not showing this, because we don't have any tests. Yeah, I cannot put a needle into that nerve to prove it to you. 4 things. What do I need to do? Physical therapy. Yeah. So I usually spend about 5 to 10 minutes in like a really bad role play of how I injure my elbow, and then I put this in the sling, and then I'm not moving my right arm. And a month from now, I take my arm out of the sling, and it sort of hurts. And yeah, what can I do? Exercise. Well, but if I do my exercise, the pain is worse. Ow. So I'm sort of overcompensating by using the other arm. Now both arms are hurting. What if I relax my arms and I'm just using my feet, and I have back pain and headaches and getting dizzy, to the point that I'm like lying on the sofa, and it's like, yeah, what went wrong here? And I involve them in a story, get the point. So I had pain, and my activity level went down, and my pain went up. And then I tried to do some exercise. The pain was terrible, so my activity level went down, pain went up. So I go through several circles of me sort of doing this, and then I give it back to you. So why am I telling you that? And we usually get to the point that Jaden, clearly she was very active a few years ago. Over the years, her activity level went down and her pain went up. And whenever somebody told her, oh, all you have to do is just sort of work through this, the wheels were falling off the bus. Alone, there's nothing. This is, yeah, you have to do 4 things at the same time. Physical therapy is just one of them. I need to do daily home exercise, and you slowly get back to normal. And you're not, yeah, the original injury is healed in your ankle, in your belly, in your head, yeah. You're not harming your body anymore by exercising. If you're thirsty, you need to drink. If you're hungry, you need to eat. If you're in pain, you need to move. Moving your painful body parts will not injure or harm you, even if the pain gets worse. That's actually a good sign. That's a part of healing. And of course, we have to do this Goldilocks style, not too much and not too little. We start very slowly, and every day and every week, it gets a little bit more, because we don't want to overdo it. Resting will make it worse. Resting will make it worse. So, Charlotte, for chronic pain, are crutches, canes, boots, relaxing on the sofa, is that helpful?
No. No, no, no. No. No, no, no. No, 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 no. No, no. No, no. No.
All right, so Charlotte seems to be quite convinced here. This isn't working. 2nd out of 4, integrative medicine. We usually talk about how, and I give this example I've done with Sandrine, sort of hitting, and why would this hurt in certain situations and not doing sports. So, and then we sort of get to the point that there's actually sort of a filter. There is a descending inhibition, that this dip nerve, that's like an off switch. So you can, by being distracted, by using exercise, you actually sort of dial down the pain inflammation. So that dip nerve, I give that sort of name, descending inhibition, that's like the off switch. We dial it sort of down. So, and I need to do something active. Active means you do this. Deep breathing, hypnosis, progressive muscle relaxation, daily home exercise. On top of that, the passive stuff is really helpful, but alone it's not going to be enough. So it's not just getting a massage or getting acupuncture. You need to do something active every day as well. And we talk about, then coming to the 3rd one, that's like, if you have a lot of pain, what's going to happen to your stress level? Well, it goes up. Well, if you have more stress, what's going to happen to your pain? Well, it goes up. But then you have more stress, and then you have more pain. And then what happens to anxiety? Well, it goes up. Well, they have pain. So we talk about the vicious cycle of sort of pain and stress and anxiety and pain and being grumpy. And so how everything is sort of connected to everything. And then I come basically, and I draw this as well, that basically we have an on switch, an on dial. If we are anxious, if we are stressed, if we are not feeling well, then the pain, of course, is much worse. So I talk about this idea of yin and yang, of sort of on switches or off switches, or on dials and off dials for that matter. And then I said, like, okay, so we have identified that increased stress and anxiety makes pain worse. So what do you think is my 3rd recommendation? How do we call people who go to college to teach people like you to learn skills to have less pain and stress? How do you call them? Dr. Christina Benke, yeah, our pain psychologist extraordinaire, right? And they come to a therapist, and they usually get this. That yes, not because you're crazy or you're faking this, because you need to learn skills in order to sort of to do this. Yeah, and then I got it, a therapist. So that's 3. Physical therapy, once a week or so, daily home exercise, practicing active mind body techniques every day, and starting see a therapist, which is basically non-negotiable if missing school, if underlying anxiety and underlying depression. And then the last thing is that that's it. One more thing. I need you to normalize your life. And let's walk this through. So is it first you normalize your life and then the pain gets better? Or is it first your pain gets better and then you normalize your life? Which is it? I usually get 50-50. If it's right, I say, awesome, correct. First, you need to normalize your life and then the pain gets better. If they don't get it, I say, nah, let's try it one more time. Yeah, I'll do a second, until they get it, yes. Yeah, and that's the key thing. We go back, that's not what they've been doing. They went out of the normal life because of the pain. Yeah, and we sort of talk about normalizing life, which are the 4 S's. Yeah, so, yeah, and do you hear the words coming out of my mouth right now? Yeah, did you hear what I just said? First, you go back to normal life, then things get better. First, you go back to normal exercise, then the pain gets better. First, you normalize your social life. God knows whatever social life is. I mean, some kids have social anxiety, right? And that's a very different approach than other kids who, yeah, so Mike, you have to sort of dial this up or down to whatever is right for this particular child. Sleep hygiene. Pretty much 100% of those kids are on Australian time zone. Yeah, so they sleep until noon, have a nap in the afternoon, are not in the evening, can't fall asleep, use their phone or whatever, fall asleep by 2 o'clock in the morning, yeah, and then up. So, and it's basically, it's very simple sleep hygiene, which is basically, I don't care when you go to bed, I care when you get up. We talk about the parents, you get up in the morning at a time when you would have breakfast. That's often a concept I then have to explain, like breakfast to a teenager, like a meal before noon. Google this. And so breakfast, personal hygiene, and being in first class. What time would that be? 7:30. Great. Then it's 7:30. On weekends, you can sleep even up to 2 hours longer. So if it's 7:30 throughout the week, then it's 9:30 on Saturday and Sunday. Once your pain is gone, I don't care what you do. Yeah, I'm just your pain doctor. I'm not your prison guard. Yeah. So this is basically where it goes there. And then we talk about going back to school. And we, of course, I go back to the cycle set. If you go back to school, especially if something going on, right, that may cause stress. More stress gives more pain, and the body says, okay, I don't want to go. So we need some sort of school re-entry plan, either going back tomorrow or 1 hour in the first week, second, maybe they have to change the school. So it depends what this is. So how did this young gentleman who was in bed for 8 months in a row, like had a chronic daily headache, was diagnosed with like a chronic migraine. How did this headache completely went away? You now headache-free after 4 months. That's very cool. How did you do that?
You guys forcing me to go to school and not taking a day off and getting into a routine.
Tell me about that.
You guys, I was, every morning I needed to get up, get ready to school, couldn't go to school late, and I needed to get back into shape and just learn how to be normal again.
So when did you for the first time thought maybe those guys are not crazy?
Probably after the first month, I started, you could see my school attendance rapidly went up and I wasn't missing as much and my grades went up, started doing more with friends, kind of started to have a normal life, attending sports, going to sporting events, and getting out of the house more.
So how did you become pain-free? So you're in so much pain for 10 months.
Missed about 40 actual school days. Yep.
Missed 40 school days.
Mm-hmm.
And then you came here, did all the hard work. So what did you do to make this pain go away?
I did lots of belly breathing and some hypnosis. I also did some exercises and aromatherapy, and I took my medications to help the pain go away.
For the parents who who often, like nobody of us has made a driver's license for sort of what to do with our kids. Like this book is great. It's written by my colleague, Lonnie Zeltzer. That has like the 12 golden rules, what to do with kids, of like not asking for pain, like when to push, we're not going to go there. Okay, I have 2 more minutes, finishing up. Medications, are they going to work? Fluffy? Any additional prescribing medications? Will this promote healing in patients with chronic pain? Yeah, so no. Yeah, so sometimes we may need something to get this over the hump. Yeah, so this I pretty much stopped using a whiff of a splash of amitriptyline. I used this in my first 10, 15 years of there. We often use gabapentin if there's a reason for that. We may use for a few days acetaminophen, Tylenol. We may use for a few days Celebrexol, Coxib, or ibuprofen. Lidocaine patches, something I might use a lot. Melatonin to help for sleep. If vitamin D levels are really low, I may substitute this. Low vitamin D level is a marker for chronic disease. It's not causing chronic disease. I may start an SSRI if my psychologist tells me that they're working on this and there's like so much treatment anxiety. I do not use SNRIs. I know that's a big thing in adult medicine. They're all unlike duloxetine. That's probably, if I want, then I do something real. I do an SSRI. Peppermint oil coated might be for sort of tummy aches. Opiates are contraindicated. Opioids and infusions usually cause more anxiety, more depression, and more worse pain. I will go over this in the interest of time. So again, talking about chronic pathophysiology, in your handouts, you find the list of all pain clinics in North America. And if you want to refer to our pain clinics in Oakland, San Francisco, internally, you just basically put in sort of an order. If you're externally, if you're outside UCSF, use this QR code. You basically, it's like referring any other patient you want transferred over here. So I hope I could convince you that chronic pain is very common, that this is something where giving medications is usually ineffective and makes things worse, and where we need an interdisciplinary rehabilitative approach, and that the expectation predicts the patient outcome. And the combination of 4 things: physical therapy, exercise, of active mind-body techniques, of psychotherapy, and normalizing life first, has the best data to research to make these kids pretty much pain-free. We run a 1-week paid masterclass every year. So if you're interested, please join us. If you want to hear much more than over just 1 hour. And open, and Christina and Karen and Alan, we will be open for questions in the remaining 2 hours.
Thank you so much, Stefan. I just want to acknowledge that it's after 1, and I know some people, including myself, actually have to move on. But appreciate it if you would want to stay on. For the people on Zoom, email Stefan with questions, because I understand that it might be hard to navigate that. But if you have time to stay,
I have time, and I'm happy to. Charlize can read the question. Okay. If it's a long question, come to the mic. Otherwise, I'll repeat it.
Can you talk about recommendations for dealing with or managing patients or presenting to the inpatient setting with chronic pain or perhaps opiates, for example, or just how to, and you like, I've already consulted the pain service.
All right. So the question is what to do. The patients are inpatient, so the trainers are already sort of is off the tracks. Like, how do we get this on? I think it's very important to have like a sort of a common plan and say that these are the kind of things we're willing to offer. Right? Is that something you're interested in? And so this would be another 1-hour talk. Yeah. So I think we do remember very complicated patients where this is sort of going on. I think it's very, very important that right at the beginning, the primary team and the pain service, we basically say, okay, this is what we're willing and can do over here. We hear you that the only thing working for you is intravenous, whatever, hydromorphone or fentanyl or something like this. For this and that reason, we would not do this, or we'd only do it 24 hours. And then, so we stick to a plan. We're very open and transparent at the beginning and follow through with this. That is probably the only way. If we do this then 3 months later, then of course it's very, very complicated to sort of change the tack and to sort of build any trust. All right. Yeah, and Dr. Benke is here as well. She has been hands-on with many of those complicated patients, so you may want to touch base with her as well. There are no other questions. Thank you very much for your attention. Have a great rest of the day.